John Lee here, welcoming you to this Irish Stew check-in episode with a guest from April 2021 who spoke to us then of his rise from rural poverty in County Limerick to healthcare leadership in the U.S. Now, Northwell Health CEO Michael J. Dowling is back to discuss his new book, The Aging Revolution, the history of geriatric healthcare and what really matters to older adults, along with news of the media company he launched and why he sees gun violence as a healthcare issue. Michael Dowling, welcome back to Irish Stew.
Thank you so much. I'm delighted to be here. It's always a pleasure, always willing to do it, and just absolutely wonderful. And I love the name Irish Stew, right? I like Irish stew, by the way. There's nothing to compare with Irish stew.
And the idea is there's a lot of different ingredients that can go into it, and people make it differently, so we want to cover the whole mix of the Irish experience. As mentioned, we're here to talk about your book, The Aging Revolution, and I was struck by that in your author's note, you took us back to where we began our first conversation, back to the tiny village of Knockaderry, County Limerick. And I could see that you never lost your drive for what drove you out of Knockaderry. It had you hopping on that milk cart, getting an education, pursuing knowledge.
Right. Well, you should never forget where you came from. And you are shaped by how you grow up. Be it good, bad, or indifferent, it helps shape part of your life. And in many ways, I grew up in some difficult circumstances, but in many ways, I was very fortunate. Yeah. But I grew up understanding the importance of family, the importance of hard work, the importance of taking responsibility for your actions, and the importance of education. I was always interested in education. My favorite pastime always, and still is reading books. My mother was a phenomenal reader. She had books around the place all the time. I quite frankly don't know where she got them. Probably from some library or a school, but I love reading books and I'm fascinated with continuous learning. You should always try to be figuring out what you should know more about. And it takes you in many different directions. Right. And I still, to this day, I read a couple of books a month. I have a massive library at home. I'm getting rid of some of them now because my wife says we need more space. Why don't you get rid of some of the books? So I give them to local libraries. But I hate to part with books because to me they're important. They're a knowledge base.
Well, I know you've written several, and The Aging Revolution covers some topics that we're all going to run into if we're not already there.
Yes, and it evolved kind of slowly over time. We was trying to figure out what to focus on, and that is what people call the graying tsunami, because we have an interesting phenomenon occurring. There are about 11,000, I'm talking about the United States, there are about 11,000 people who turn 65 every day. We're all living about 35 years longer than people lived in the 1910s and the 1920s. In the U.S., by the year 2035, there will be more people over age 65 than there will be young people. So it raises all sorts of interesting issues, and I focused a lot on the healthcare issues in the book, but it raises large economic and social issues because we've always gone in the assumption that you'd have 3 workers, 4 workers for every person retired. But what's happening in the United States and in many countries, Italy, China, other countries, the fertility rates are coming down, so families are having less kids. Go back 15 years ago, every family had 2.6 kids. Right. Today it's 1.6. So the number of kids in families are decreasing, but the number of older people is increasing. And it creates this huge imbalance. At one time you had 3 workers for every 1 elderly. You're going to end up having 3 elderly for every 1 worker. Now think through the implications of that. What does that mean economically, tax-wise? What does it mean? Employment-wise, what does it mean, etc. So that's a much more global issue. I mean, there are some people who would argue, and I would be one, that one of the ways you solve this gap, because it's very hard to get younger people to have more kids.
Right.
Nobody seriously wants to reduce the aging process, reduce longevity. So many people will argue the way that you fill the gap to create the workforce to support the elderly population is immigration. And legal immigration. I'm not getting into the stuff that we spend a lot of time talking about, but that's the immigration question that should be addressed. In many ways, not the immigration debate that we have politically at the moment, which is so partisan and political. The book is not about those issues, even though it's implied. It's mostly about on the healthcare issues. What do we do healthcare-wise? And I remember not that long ago when I started out working at Northwell University Hospital back in the early 90s, that there was not a recognition by many, many physicians at all that there was such a thing as geriatric medicine. Now, should older people be treated a little bit differently because of their uniqueness from younger people? Is a 30-year-old the same as a 70-year-old? There was this theory that there was no difference, just like at one time, not that long ago, 30, 40 years ago, there was an argument that there wasn't such a thing as pediatric medicine. There were just smaller individuals.
Right.
Well, today, we have evolved. And I wanted to trace the history of geriatric medicine. Who are the people that created in the healthcare space a field of interest called geriatric medicine?
Well, Michael, you started off here already telling stories and narrative.
Yeah.
Is there a story in particular that really stuck out about what you discovered in this book, a story you tell in this book that remains in your mind?
Well, the story of a guy named Robert Butler is fascinating to me. Most people don't know who he was. I happened to meet him a couple of times. He passed away, I believe, in around the year 2010. But I had met him a couple of times. He was a fascinating individual. But he was the person who wrote a book back in the 70s called Why Survive? Growing Old in America. And he was frustrated with the lack of focus on the issues of the elderly. So that was something that I was very, very interested in. And there's a whole section of the book that talks about his career and what he did to push the agenda. The other issue was end-of-life care, hospice care. My mother was in hospice. It's an interesting story. My mother had got cancer. She was over here with me when she had it. We sent her back to Ireland. She had cancer surgery, which worked. She lived another number of years, but then she got sick and she ended up in a hospice in Limerick. And I would go visit, and it was a wonderful place right outside Limerick City. I forget the exact name of it today, but it was a wonderful hospice. And I was here at Northwell. It wasn't called Northwell back then. And we had no hospice programs here. So I created the first hospice program in Northwell as a result of my experience with my mother in the hospice program in Limerick.
More developed over there.
Yes, it was. Well, hospice was initiated basically in England and Ireland and in parts of Northern Europe much earlier than here. So when I came back here, I opened up an inpatient hospice program here. But then we expanded it today. We have inpatient hospice, hospice at home, etc. So that story was always of interest to me. Why is it that there is less of an understanding of the need for elderly care here? So the book kind of emanated from those issues. We don't have enough geriatricians that are trained in geriatric medicine, especially in the U.S. I'm not exactly familiar with what happens in Ireland these days, but in the U.S., not as much.
One story that stuck with me was a story about a doctor who was new to a VA hospital.
Yeah.
It's a Veterans Administration hospital for our international listeners, seeing older patients who came in okay slide into dementia while they were in the hospital. She was alarmed, and her colleagues just said, "Don't worry, it just happens."
Well, that was very, very common. And in fact, a story that's not in the book is that when I was in government, and I was very involved with mental health, and we had lots of inpatient institutions for mental health. A lot of the people in the mental institutions were elderly, suffering from dementia, memory loss. This was in the early 60s when they ended up in the facilities. And it was before the appreciation of the fact that this was an aging issue, and also before medication. So I was amazed when I used to go to the psychiatric institutions to find older people who were not mentally ill.
Right.
They had dementia. But back in the early 60s, they acted differently, so they ended up in an institution. So a lot of people ended up where they shouldn't end up because there wasn't the focus on deciding and determining what exactly was wrong with them. And the VA, which has improved over the years, but the book talks about some of those people. So the book basically is the history of the people who made the change, and it's still continuing.
You talk about breakthroughs in the way people think about this topic. Is there a key breakthrough or two that you would say really moved the needle in people's thinking about this?
One of the breakthroughs is what you got to be doing to prevent falls were a big part of people dying and having severe injury. But there was a lot of research done on falls by Mary Tinetti, if I remember correctly now. And she did a lot of research that if you did the prevention, you assessed the diagnosis cases, you could predict who would potentially fall, and you could put in place practices to prevent it from happening. The other issue was that a person doesn't have to be in an institution. They can be at home. And if we create programs like a program we have called Independence at Home, that was a lot of people focused on this, which is also in the book. And we have in Northwell right now a huge home care program. And with technology these days, you can remote monitor people at home. You can educate the family of the people at home. You can provide services at the home. You don't have to bring somebody into the hospital for care. You can take the care to the home.
It's an ordeal to get someone to the hospital.
Yeah. And older individuals, home is important. It's that sense of belonging. You take them out of their comfort location and you put them into a different, completely unique circumstance. They can completely change, both mentally, physically, and emotionally. Yeah. And so to the extent you can keep people at home, the better. And that's an area that we focus on all the time. So that's essentially what the book is about. Today now the whole discussion is around what we call age-friendly health system.
That was going to be my next question, and I'll frame it up because you mentioned politics and the sort of ugliness around it right now. And not to be too political, but this year's presidential campaign in the U.S. has cast a pretty harsh light on what I think you would consider as the uglyism of ageism. How do we move from ageism to age-friendly?
It's a baffling circumstance because we all want to age. There is nobody that says, I don't want to get older. And I think if you can personalize this to an extent and you ask the question to yourself, well, I will be old at some point. So you'll have a presidential candidate like Joe Biden, whom I knew personally, who obviously is suffering some issues, is slowing down as they're aging. Right. Given his career, given what he's accomplished, it's a natural progression and it requires understanding. But current politics is toxic. So we should have respect for people as they get older because we will be there someday ourselves. Right. And so I think people should just look in the mirror and say, when I am 75 and if I slow down a little bit, how do I want to be treated? How do I want people to talk about me? And you definitely don't want to be talked about the way some of the politics talks about some older people today.
Exactly. You know, I'm diving into this demographic myself, and I have to say, I found like I was going to go out and read this in the park, and I felt a little self-conscious, the aging revolution. So it is there's a barrier in your mind. You do want to get older, but you don't want to admit that you're older.
Yeah. Well, in many ways, the aging issue and longevity, it's a crisis of success.
Right.
And not a crisis of failure of healthcare. Healthcare has been phenomenally successful in being able to do things today that we couldn't imagine doing 40 years ago. And because we can do them now, people live longer. We have more and more tools at our disposal today to keep people alive longer. Heart disease. I, for example, have a cardiac issue. I have 3 stents that were put in about 15 years ago. I had a 96% blockage in my main artery. Before the world of stents, which didn't happen until 1981, I would not be here. I wouldn't have benefited from the aging process if that hadn't been progress in medical science and research. So we're in a very fortunate place. The fact that we can talk about an older population means that we've done an awful lot of things successfully. But now we've got to continue dealing with elderly people in a more appropriate way. And one last thing I'll mention. Not all older people are the same. There are very healthy old people. There are older people who are completely functional and working. Many executives in many companies are in their 70s, many in their 80s. And then you have a cohort that are low income and having severe difficulty, are people who are not low income who have major health problems. So it's not a homogeneous population, which you got to be careful of. You and I I'll be 75 in November. I consider myself a pretty healthy older person.
72 for me.
And I'm proud of it.
Yeah.
And I want to be moving around and be healthy when I'm 80.
Right.
But at some point, I know that it'll slow down. My mental acuity won't be there. My physical ability won't be there. That's natural progression. The fact that you can exist for 70 healthy years is a good positive sign. And the more active you stay, the more active you become. And the book talks about this. The more active you stay, the better likelihood you're going to be around for quite a while.
Yeah, just a second ago, you mentioned different kinds of populations.
Yeah.
And with this move towards a new way of looking at geriatric healthcare must come cultural understanding and understanding of economic situations and understanding of the environment people.
Sure.
So it's not one size.
It's not one fit. I mean, and this is where if you're running a healthcare system, you've got to be very attentive to the different cohorts. Just like on anything, if you're dealing with an Irish population, it's different than dealing with a Hispanic population. We're all the same, but we're always a little bit different.
Yeah.
And the circumstances that you grow up in, the kind of a family circumstance you're in, like home care I mentioned, in many cases, if the home is suitable, you can accommodate very good home care. But if you live in a one-bedroom apartment or a two-bedroom apartment, you don't have any facilities at home, it makes it a lot more difficult. Yeah. And so everybody is individualistic to an extent. So you have to deal with the generic at the same time you're dealing with the individual aspects of each case.
One thing I liked about the book is the people that you spotlight.
Yes.
You know, people telling stories all throughout the book. And a lot of them are the innovators in the space and the people who are pushing through the change and wrapping their heads around understanding what they're dealing with here. So there's patients, there's caregivers, there's practitioners, administrators. I found the idea of the pressures on practitioners particularly of interest. How can healthcare practitioners in their real daily life keep up with the sort of changes in thinking and the new regimens and new protocols?
It's much harder today than it was because there's a lot more new research, a lot more new discoveries, a lot more new thinking today than there was before. It was relatively easy to be a doctor 40 years ago. You probably had 20 medications.
You had the little bag that
you had a little bag. You could take your whole library in your bag.
Yeah.
Today, thousands. And then the interaction between all of the various medications and therapies and treatments, etc. But this is where ongoing education is very, very, very important. This is where the curriculum that you develop in the medical schools and the nursing schools, all of this has to be continuously revamped and transformed. So, for example, our medical school curriculum is completely different than the medical school curriculum of most other medical schools. And we purposefully did it that way because you can't expect people to work differently today, given the circumstances, and teach them and train them the way you trained people 40, 50 years ago.
Right.
It's how you educate. It's the result at the end of the day is the result of what it is you put in when you educate and train people. So we adapt big time on this. Continuing education. A real gap applying to the book, obviously, is the shortage of geriatricians.
Yeah.
People who are educated on geriatric medicine.
And I think it comes out that in Europe, it's much more common.
In Europe, yes, and more so. But we'll make headway here. The more that you get the issue out in public, the more you talk about it, the more people are more interested in it. Now, every doctor deals with older people. If you're the cardiologist or the transplant guy who replaces your heart, he's dealing with older people primarily.
Right.
So how you deal with the complexity and the uniqueness of an elderly individual and the family dynamics of an elderly individual, all of that stuff with the specialists is something that we focus on quite a bit here.
So you really need to develop a narrative from your patients.
And you've got to listen to the patients.
Yeah.
I mean, the famous phrase I like is, it's not the doctor asking you, what's the matter with you? It's the question should be, what matters to you?
That's great.
It's a different focus.
Yeah.
Because patients today are much more involved in their care as a partner with the physician and the nurse. Remember, nursing is huge here.
Yes.
In the old days, and of course there's always exceptions, it was all about what the doctor thought and the patient didn't have much of a say. I remember my mother when she was sick. She never wanted to disrupt the doctor by asking a question. Right? She'd say to me, well, he's busy.
Yeah.
Or he's got a lot on his mind. And I'd say, Mom, You're busy too. This is why, by the way, I use the term customer instead of patient. To me, a patient is a customer. You're a customer of our service.
And that customer has other places to go.
Sure. If I don't treat you well, you go someplace else.
Right.
It's not like I, the doc, I, the system, know everything and you know nothing. Our issue is you know a lot and we've got to listen to it. And now with social media all over the place, which has a big downside as well, but there's the positive side to it. And when I go to a local library in my community, which is very interesting, I go to the local library sometimes to just lock myself away and do some thinking. Most of the people on the computers are older people. You know, it sounds like it's a lot of young people, yeah, but it's a lot of older people who get a lot more information, can search and go on chat rooms and find out where the good services are and the not so good services are.
Everybody's rated and ranked. And
the democratization of information using social media is very positive, even though there is a negative side to it.
I want to go back to one thing you said there about the important question of what matters.
Yeah.
As someone is dealing with a series of medical problems.
Yeah.
Towards the end of the book, you talk about a focus on a simple phrase in the context, the quote, patient's actionable, realistic health outcome goals. The phrase was that one thing.
Yeah.
What's the significance of that?
You know, it's getting input as to what really matters to the person. For example, let's say I have a lot of issues, but I want to live at home. That's the one thing. Or I want to be able to have dinner with my daughter. Or I want to be able to go to my local, like in an island, like the bingo game.
Right.
That's the one thing.
Yeah.
Or I know I have a serious problem, but I'd like to be able to go for a walk.
Right.
Okay. So full understanding, there's a lot of other complications, but it gives the perspective from the customer about what really they think, not about what the doctor only says. The doctor says, this is only what you should do.
Right.
You say, no, okay, I get that, but let me tell you what I want to do.
There was someone in the book it was an example of somebody who was like, I'm willing to live with a little pain as long as I don't get all dulled out and,
Yeah, I don't want to be catatonic.
Yeah.
I can live with discomfort, but I want to be able to talk to my granddaughter.
I want to just move to another aspect. We've been talking about storytelling. I like to weave in the Irish aspect here, Irish storytelling, and how you can use that Irish gift of storytelling to advance the narrative that you worked on here in your book, how you amplify it. And I've been riveted recently by watching the Netflix documentary series, Lenox Hill, filmed at your flagship facility here in New York. And I know there's other programming, Emergency NYC and other programming in the pipeline, but you recently announced the launch of Northwell Studios with some powerhouse partners. Tell us a little bit about that storytelling initiative and what's going to be the end result.
Well, I got to tell you, this has been very, very interesting because I put out a release about Northwell Studios. I haven't received as much information on most things that I've received with regard to this issue. Then Wall Street Journal, I had to meet with them personally on it, New York Times, media.
Hollywood Reporter.
So the issue was everybody thought that I am building a studio. Like if you're making a Western movie, I'm going to build a studio. And so the way I've explained this is we have been one of the few organizations that has continuously over the last 10 years created major documentaries that tells the story to the outside world about what goes on the inside healthcare world. So we did First Wave. So when I allowed a documentary crew into one of our big hospitals during COVID, because remember, this was at a time when the public couldn't come in. Families of patients couldn't come in. Everybody was banned. The only people who were in the hospitals were staff and the patients. I was in a COVID unit every day. I walked every COVID unit in all of our facilities. So I let a documentary crew in to tell the story. Now, at the time, I remember it vividly. It was kind of scary because you were wondering, is the documentary film crew going to do it right? Are they going to protect privacy? But the story that comes out after doing 850 hours of film that turned it into another 50 minutes It is, as far as I know, the only documentary that shows what happened inside a major hospital with 800 COVID patients on a day-to-day basis. It's a phenomenal documentary. The people that watch it tell me that it's been completely eye-opening. And you see tough stuff. It's the real world. It's not ER on television.
Right.
It's the real world. And so we did that, and then we did Lenox, which you referenced. We did Emergency NYC, which is another phenomenal show. And then we had a new one just come out 3 weeks ago on mental health. And it's an HBO movie, a 2-hour documentary, not a movie, 2-hour documentary, showing what we've been doing for quite a number of years to prevent college kids from committing suicide. It's on HBO right now. So the studio is not a new entity. The studio is my hospitals,
Right.
my facilities.
Right.
So I'm using my facilities to display informational, educational material to the public to tell the story about what really goes on inside these big institutions that everybody walks by. And that they know that they want to be there if they're very sick, but most of them, they don't ever want to be there. They only want to be there if they get sick. But they should know what goes on in there. It tells the healthcare story. That's what the studio is. I can tell you that I had to spend an hour with the Wall Street Journal to convince them I wasn't physically building a studio.
Right.
I said, my studio is my hospitals. Right. The reason I put out the release that got all the attention is I wanted to focus on this more. So we have Netflix now talking to us again.
Right.
They're going to do another show. I have multiple companies now coming to us saying, we'd like to do a show on XYZ. Can we have access? And we go through this very, very carefully.
It must be quite a process.
We pick people, good people, and we try to do it the right way. For example, we have a nurse choir. We have a very famous nurse choir at Northwell. It got to the finals of America Got Talent. They have played Carnegie Hall. They've played every major arena in the United States, etc. Been on television. They did the White House Christmas show in the White House. So we had a production company coming to us and say, we'd like to do a documentary on the choir. Right? We have not decided on any of these yet, but I set it up as a separate entity with a separate focus of staff so that we can deliberately do this the right way. I think this is important to do, and we'll be doing more of it. And I think the public benefits. The staff is all willing and open to do this, as long as you have the right company doing it to make sure that every patient's privacy is protected. If you show a patient, they have to give their permission and their approval, et cetera, et cetera. But it's all doable, and we've demonstrated.
Yeah.
So that's what the studio is.
Right.
People will watch TV and they'll see a medical show. That's acting. You want to know what goes on? See the real stuff.
We've been binge watching the old series House.
Yeah.
Oh, yeah. And this has been a very good counterbalance.
Yeah.
We enjoy the show, all that, but this is the real thing. And people in New York will recognize the buildings.
Yeah. And it's difficult for some people to watch.
Yeah. No. We kind of hit the end of an episode and I go, okay, I think I need to relax a little bit here.
Yeah. And you see the
real warts and all too.
You see the real surgery, and we've had unbelievable cases, and you see birth. You see the real brain surgery.
Yeah.
And you get to understand what it's like. And the physicians and the doctors and the surgeons, actually, the two surgeons that are in the Netflix Lenox Hill show, I actually was with this morning.
Oh.
Because they're probably going to be in another one because they're absolutely wonderful.
They did very well.
They want to be Hollywood actors now, but I want them here doing surgery.
This is what happens once you get on TV.
Yeah.
Well, you mentioned some important stories to tell. I'd like to just close off on one other issue that I know you're very concerned with. And I'm very fascinated with how you have cast gun violence as a public health issue.
Right. We have to start defining healthcare broadly. It is a lot more than the provision of medical services. Everything affects health. A good education affects health. Allowing a person to get a good job affects the health of that person and their family. So there are these social issues that have a direct impact on health, and one of them is gun violence. So I got involved about 6 years ago or so when we had a lot of the mass shootings. But mass shootings are only about 2%, less than 2% of overall deaths. But there's a statistic that is shameful to be able to state, and we should be embarrassed by it. And that is that guns are the leading cause of death for kids and adolescents in the United States. That is an embarrassing circumstance. The number 2 leading cause of death is automobile accidents, and the 3rd leading cause of death is cancer. Now, in all of those cases, there are severe health issues, physical health issues. There are severe mental health issues. There are personality issues, personality changes. So it's a health issue. We have had, in about a year and a half recently, we've had over a 400% increase in the number of kids coming to our children's hospital as a result of gun injuries. In one of the documentaries that was done, Emergency NYC, there's a whole section of that about one teenager who was shot by a gang member that came to our children's hospital. And you're there and you had the families who were terribly distraught. And quite frankly, some of the families of the person who does the shooting. Of course. There's both sides to the story.
Yeah.
Because the trouble with a gun is it takes just a flicker of the finger and it's over.
Right.
And it's instantaneous. So I took on this issue as a public health issue. I am not addressing the issue of the right to bear arms or the Second Amendment. This is a health issue that affects the well-being of families and kids. They end up in our facilities, mental health facilities or physical health facilities, and we have a responsibility. Cancer is a leading cause of death. We focus on children's cancer. Why not focus on the number 1 leading cause of death? Gun violence. And when I started, I got very little support. I was basically out by myself, and everybody was telling me, it's a lane too far. It's a bridge too far. Stay in your lane. This is not your lane. I took a lot of criticism and some threats. Today, I have a national coalition of CEOs from all over the country, from every state, Texas, Alabama, Mississippi, the West Coast, Utah, all over, partnering with me. It's called the National CEO Council on Gun Violence. We organized a big meeting in the White House about 2 months ago. I gave the keynote at the White House meeting, and we will be launching a national educational campaign on gun violence by the Ad Council in February, because we hold a big event every February here on gun violence. The last year's event, the keynote speaker was Bill Clinton. Came. And so to me, this is a very, very important issue. And let me draw an analogy. At one time, automobiles were one of the leading causes of death. And many people who are listening may not remember the name Ralph Nader.
Yep.
So we never banned cars. We made cars safer. Right. Seat belts, airbags, speed limits, traffic lights, car construction, and car deaths plummeted. The guns, in many ways, are the same. You can have guns, but you got to make them safe. Right. One of the issues that we're focusing on locally, and we've done ads on this on television, if you have a gun at home, the question is the gun locked up? Many of the disastrous things that occur, like recently, you had a situation of an 8-year-old, 7 and 8-year-old who went to school, picked up a gun in the home, went to school and shot the teacher.
Yeah.
These are preventable things where you don't have to deal with the Second Amendment issue. And I'll give you one last question. I was out in Utah last week, and I had to give speeches at the University of Utah. And I'm with the head of the big system in Utah. It's called Intermountain. It's a system we do a lot of work with. And the CEO there is Rob Allen. He's very involved with me now on the gun violence issue. Utah is a red state. Everybody in Utah owns a gun. Yet Rob Allen was very complimentary about I getting him involved because he has become so popular for his stance on gun violence prevention and safety. He says, I have received thousands of positive messages, 0 negative, in a state where guns are all over the place. So if you stick with it as a public health issue, and you talk about the importance of preventing injury to kids, it's a health issue, It's a public health issue, and you will garner a lot of support. So that's how I focus it. I had a big meeting with the CEO Council last week, actually, 60 CEOs on. When I held my conference last spring, I had the mayor of a big city in Texas come and speak. Texas, yeah. He came and spoke about the importance of prevention and safety for guns. And the United States is unique here. I mean, this doesn't make a lot of sense in Ireland or in other European countries, etc.
Although they see the movies and the TV.
They see the movies.
They glorify a lot of this.
And they glorified it. And of course, the politics in the United States, it's like guns, guns, guns. Yeah, I get all of that. But that doesn't mean you can make an improvement in what happens, what guns do to people. One of the things we do, for example, every time anybody comes to our emergency department now, we ask them about guns. Did they have experience with gun violence? Is there a gun at home? If there is a gun at home, we give them free locks to go home and tell the parents to lock it up. Right? And it makes a difference. You know, remember, every big thing is the result of a multitude of small things.
It's like the geriatric book here. Yeah.
I mean, that book is only it just touches the tipping point. There's other books that can evolve from this.
Yeah.
Not necessarily by me, but by others. And we're making progress on the guns. There has been a reduction in gun deaths. We still had this year alone already about 30 mass shootings. Because a mass shooting is anything that occurs where more than 4 people get injured or killed. And we had the one in Georgia recently with a 14-year-old whose parents bought him an AK-47 for his 14th birthday. Yep. And that's why that parent is now being charged as well.
So there's some new thinking too.
So that's a whole other issue, especially in that case, and I don't know all the detail, but from what I read in the papers is that the kid had some issues.
Yeah.
So why buy him a gun?
Yeah. That kind of gun too.
And that kind of a gun.
Yeah.
And I raised this at the meeting of my CEO Council last week, and I got a lot of positive feedback. Is why should we not ban assault weapons, military-style weapons? Who on a street needs an assault weapon? Unless they're willing to do bad things.
Right.
So I think you're going to get more attention to this. There'll be more willingness to talk about it. And I'm not hesitant at all. I talk about it. And I've had some very nasty responses about people saying, oh, you're too liberal, you're off the wall, etc. Well, if I'm off the wall for trying to protect kids from being killed by guns, then I'm off the wall and I'll be proud to be there.
Right. Well, it sounds like one of those issues that you're finding a new way to tell a story. You're shifting the narrative as you've done here in the
It's like other things. I mean, what responsibility does the food industry have to produce food that is healthy? Right? If you produce food that is full of sugar and salt and other chemicals that is bad for your health, do you have a responsibility? I think so.
The quality and the freshness and the preservation. And
when you're in the hospital delivery business, I mean, I have a lot more stuff than hospitals here. Most of my business is non-hospitals. But when you're in the side of the world I'm in, and people end up obese, we seem to get blamed for it, but we're not the ones causing it.
Right.
We got to get to the cause.
Yeah.
If we treat an obese child of 12 years old, I don't make them obese.
Right.
I deal with the response to obesity. But we got to go upstream to figure out why did that kid, unless it's a genetic issue, why is that kid so obese?
Yeah.
And that's a community responsibility because we're all paying the price for it.
Michael, in our first episode we did with you on your excellent book, After the Roof Caved In, your memoir, we tagged you as a healthcare optimist.
Yeah.
Are you still an optimist?
Oh, absolutely. Because let's ask the question, what's the alternative? You want to be a pessimist? Who listens to pessimists? We have some pessimists running for president that talk about everything is so bad. Those are fleeting things, and fleeting may mean a couple of years before. But if you want to inspire people positively, you've got to be an optimist. We're very fortunate. Despite all of the crap that goes on and all the craziness that we can talk about, we're quite fortunate, especially when in the United States. I meet all new employees that are hired in the health system. We hired almost 300 a week. I meet them all every Monday and every Friday. Like this past Monday, I hired 200 people. I spent 3 hours with them, and the other 100 will be Friday. So I talk about this. I said, you might complain about how things are uncomfortable and you have a bad day, etc., but you're very, very fortunate. You're not living in Gaza right now. You're not living in Kiev in Ukraine right now, where you and your family have to go underground because you're not so sure when you hear the siren that there's not a bomb landing on your house. That's the problem. You don't have these problems here. So in many ways, we're very, very fortunate. We've got good health care. We're living longer. So there's a lot of reason to be optimist, but everybody has got to be an advocate to do something to make sure that we can improve the situation going forward. You can't sit on the sidelines. We have way too many people sitting on the sidelines whining. It's like if you play hurling, which I did, and you want to win, you got to go on the field and play.
Yep.
Don't sit on the bleachers complaining.
Right.
And it's everybody's responsibility to be in the arena. And to be optimistic. Positive attitude is good for your health.
And even if the odds are against you going into the hurling match, you still got to play the game. And
well, you don't ever want to go in. If you're in the locker room before a game and some of your co-players say to you, we're definitely going to lose today, that's not an attitude. Right. You go in to win. You might lose, but you go in to win.
Right.
And if you give it your best effort and you come out at the wrong end of the score, you're still a winner. You may go home a little bit unhappy, but you get better for the next game. And it's the same here. It's not that different. So, yeah, you've got to inspire people to be positive about what's possible. And you've got to get them to do more than they think is possible.
Michael, thank you so much. It's been great talking about your recent book, The Aging Revolution, and all the other great topics we've covered. I love a conversation that you don't want to end.
Well, thank you so much. I'm delighted that we're getting together again. More than delighted to do it at another time and keep talking about what's possible.
Irish Stew is produced by John Lee, Martin Nutty, and Bill Schultz. Editing, mixing, and mastering by Bill Schultz. Music on Irish Stew was composed and performed by Rosa Nutty, with Donald Bowens on drums, Cathal O'Riordan on bass and synthesizer. For more on Rosa Nutty's music, please visit rosanutty.com.